evening, everybody, and welcome to the Mental Health Professionals Network Interdisciplinary Panel Case Study discussion on working together, working better to support a young person who's experiencing cyberbullying. We have an increased number of participants tonight with a more advanced platform than has been used for previous panels, and there were over 700 people expressed an interest in attending tonight. I think there's about over 200 on our webinar tonight, so be aware that you're in a large room of people. Just a reminder that if your mobile phone's in the vicinity of where you are, please put it onto silent. And, oh, actually, you don't need to do that. That's for the presenters. So from that, you can tell this is my first time facilitating a national webinar. My name's Mary Emilias, and I'm a GP from Cairns. I work at Headspace, and I have worked in a Headspace setting for over 4 years, first of all in Townsville and then most recently in Cairns. I'd like to introduce to you our panel members. So, first of all, Brooke Chapman is a qualified social worker and a youth worker based in Perth in Western Australia. Brooke currently lectures and tutors in youth work at Edith Cowan University, and she works at a secondary school as a school counsellor. She's also the Secretary and Membership Officer to the Western Australian Association of Youth Work. Welcome, Brooke, and I guess in your role as a school counsellor, cyberbullying would be something that you're probably having to deal with every day. So it's great to have you on the panel.
Thanks.
Liz Scott is a Sydney, New South Wales-based psychiatrist. Liz is currently the Senior Consultant Psychiatrist at the Brain and Mind Research Institute and Conjoint Lecturer at the School of Medical Sciences at the University of Sydney. Liz has considerable clinical expertise in the assessment and management of patients with depression and anxiety disorders, and has extensive experience in developing and evaluating comprehensive assessment and management programs for young people with mental health problems through her work with the Brain Mind Research Institute and the new National Youth Mental Health Foundation, which is Headspace, in the southwest of Sydney. She's also a long and distinguished record of research activity, so welcome to you, Liz.
Thank you.
Simon is a clinical psychologist based in Melbourne, Victoria, and he has over 17 years' experience. His PhD researched the links between family conflict, family functioning and life satisfaction. He was a senior clinical psychologist in the Austin Health Child and Adolescent Mental Health Service and in the Adolescent Day Program in the Albert Road Clinic. Currently, Simon works full-time in private practice where he consults children, adolescents, families and adults. He is an honorary fellow in the Department of Child and Adolescent Psychiatry at the University of Melbourne. So I think we've got a great range of presenters tonight with a lot of experience working with young people. And I'm also very pleased to see that we have people from every state, well, from 4 states on the panel. So I'm from Queensland, Simon's from Victoria, Liz from New South Wales, and Brooke from Western Australia. And I think this is representative of our participants as well, so welcome to everybody. Currently we have 244 participants and climbing. So I'll just give you a little bit of an outline of how we're going to proceed. So first of all, with our learning objectives, by the end of tonight's webinar, hopefully, you will be better equipped to recognise the key principles of intervention and the roles of different disciplines in assessing, treating and supporting a young person who is experiencing cyberbullying, and to better understand the merits, challenges and opportunities in providing collaborative care to a young person who's experiencing cyberbullying. What we've already sent to you the case study, and I hope you've had a chance to read it. So we're going to be talking about Kelly, who is 16 and she's been experiencing cyberbullying. It's an important topic for primary care clinicians because it's something that's increasingly common and can be really distressing to young people. I guess one of the things I noticed about the case we were sent with Kelly is that there's a number of issues going on. It's quite a complex case. However, rather than being a negative for us, I think it's actually very reflective of what happens in real life. So we don't see someone who presents with just one issue very often. Usually people have a lot of things going on. So what I'm going to do is invite each of our presenters to give a discipline-specific response to the case, so how they would approach it from their discipline background. And then there's some questions that our presenters have for each other. Now, I've also been able to read the questions that the participants submitted when you registered, and I think that you'll find our presenters do cover a lot of the content you've asked, and also we'll make sure that given enough time, we'll cover as many of the questions that you submitted as possible. So what I would like to do, without going on any further, is to hand over to Brooke, and who's going to talk to us about a social work perspective in this case. Thanks, Brooke.
Okay, thanks. So, firstly, the role of social work in its response to cases of cyberbullying in schools. I think that as a social worker and also with my own youth work experience, that I can use this role in schools to advocate for good cyberspace practice policies for schools, and to further, or if you were to work in a school, and further to intervene in cases of cyberbullying so that young people can feel safe to attend school without feeling threatened or further marginalised, either in a school setting or in a classroom. So if I was to meet Kelly, the first thing that I would do was introduce myself, and I would explain my role and how I can help students and families, because sometimes students think that they can mistake you as a teacher. So you want to make it quite clear that you're not a teacher, that your role is quite different. So I would also explain confidentiality, because here in WA we do have mandatory reporting as well, so that can affect, I think that young people have the right to know that straight up, whether it may not be to do with cyberbullying but other issues. So I explain what confidentiality means at school. And I also would then ask what prompted Kelly to make an appointment with me or to just come and see me. So I'd establish the facts first by completing a genogram, which is a bit of, so I can see the family structure that Kelly has come from. And I would complete a timeline of events to clarify significant events that have happened throughout over a period of time for Kelly. And I would check with Kelly that the genogram and timeline match her recollection of her experiences over time that she has shared with me, so that I don't get the information wrong. The next thing I would do is identify significant key issues that might increase Kelly's risk of stress and harm or her anxiety. So I would take notice of the particular language Kelly uses to describe her situation or her feelings and her needs. And I would take notice of where she repeats perhaps her description of feelings or what has been happening for her, because that would indicate to me that there are areas of importance for her. And note any indicators of strengths or areas of vulnerability, whether physically, emotionally, or socially. So whether I would observe things like her body language and her language, or things that are happening between her and her friends. I'll identify key relationships or safe, supportive people in Kelly's peer network or local community. So, for example, she mentioned a relationship that was important to her. Or if there was a past worker, they're strengths that you can use when working with her. So the key issues that I identified in this case would be that the cyberbullying threats were causing increasing stress, worry, and anxiety for Kelly. And so therefore, if this was to continue, then I would be worried about what would happen next for her. The history of untreated anxiety and depression that seems to have existed for a long period of time, and that it was, I think in the case study it says it was her mum that took her, or it was the person she was staying with that took her off the medication, so rather than a GP, for example. And this has obviously been compounded, or the depression and anxiety has been compounded by recent homelessness and her street presence. So she's been quite transient for a period of time. There's no real long-term stability for accommodation or realistic planning to consolidate this in the near future once hostel accommodation ceases. So I'd be concerned that if it was like a 3-month stay, that what's going to happen to Kelly next? So her long-term stability seems to be a little up in the air for her. Other key issues, lack of reliable, secure parental support or other significant adults who act as a positive and caring role model in her regular day. That would concern me as well. Long period, recently, of disengagement from education, causing risk of increasing gaps in her learning and academic development. So when young people are being disengaged from education for, 3 months at school and then not coming to school for another month, then come to school for 2 weeks, and you lose them again for however many weeks, that's a real concern as well, because it means that during that time there's stuff happening for them. Reoccurring nightmares causing lack of quality sleep, indicating anxiety and fear could be heightened in the evenings, being experienced in many spheres of her life. So at night time it could be, it's bothering her more, and then it's also affecting her during the daytime. So my intervention plan would be to dialogue with Kelly about accessing, with my support, additional community resources to address key issues outside of the school. Complete relevant interagency confidentiality and communication forms to avoid any administration roadblocks that may delay the helping process later. Sometimes when talking to other agencies on behalf of Kelly, or if Kelly's in the room, it can be agencies have different protocols, perhaps about whether they talk to the worker or whether they talk to Kelly directly. So I want to try and fast track that as best I could so that we can get somewhere with Kelly. I'd make relevant phone calls with Kelly's permission to a housing officer at the hostel, for example, to optimise access to resources and to avoid overlapping in professional helping. Some hostels might have a youth-friendly visiting GP who can conduct an assessment in an environment that feels comfortable for Kelly, and that could be provided free for her. If Kelly's in the school, then I would also try and access a school psychologist. That would probably be another option that I could take. And I'd advocate to relevant school teachers about any barriers that with Kelly's permission, any barriers that she might have to her education at this time that could be affecting her academic performance or her attendance. And if it's cyberbullying in particular, then we would need to act on that. I'd complete and involve Kelly in any other immediate care plan actions, such as health checks, so that she can access services like Medicare, identification cards, Smart Rider. Often when you're working with young people and you need to refer them to agencies or get them to a doctor, then sometimes I'll say, well, I can't get the bus or train because I've got train fines and I need a Smart Rider, or they don't have any ID on them from when they left home. So I'd have to make sure that Kelly's got all the information she needs. And I would also refer to the cyberbullying policy of the school or of that particular state, and engage in discussion about the concept of privacy with Kelly and what that means and looks like to Kelly in her life, because we have to acknowledge that young people live a lot of their lives online. So educate Kelly about cyber safety, and do so by perhaps sit with her at the computer, facilitate her learning, take her to some websites that can help act and help teach them about cyberbullying and how to manage it, and allow her to experience feeling sort of in control and more knowledgeable about her options in managing her online life, and empower her to reclaim her privacy by using simple tips and strategies like perhaps altering, resetting privacy settings, keeping transcripts of bullying to print out, limit or make invisible her profile to reduce exposure to risk of cyberbullying, and teach her things as well, like if she's experiencing anxiety, I could teach her some breathing techniques to help manage that when it was affecting her at school. So some other coping mechanisms, and Kelly and I could try these out when she's at school. Teach her ways to reduce the stress, and provide individual class and even whole school approaches, utilising pastoral care teams and students who can promote safe social networking, like perhaps the student guild would be a good option as well. So involve the students somehow that is school appropriate to help the school and to help particular classes, or to develop a more positive attitude about cyberbullying.
Thank you, Brooke. That's a fantastic, comprehensive start to our discussion. I just had a couple of questions because I've not heard the term street presence before. Could you just explain a little bit more about what that means in case others haven't heard of it too?
Sure. So street presence means that the young people who aren't living at home with perhaps with a mum and dad or with caregivers. So in my experience, I've worked a lot with young people who are 16 years old and who are considered to be independent. So they're not living at home. They could be just sleeping at friends' houses night to night, and they're all living in a hostel. But they spend a lot of time on the streets, in public space, in public places and public spaces.
Okay, thank you. And I've heard the expression couch surfing as well.
Yeah.
And I also noticed that you mentioned a Smart Rider card, which I think is a Western Australian specific transport thing, but it does raise a couple of points. So one is that we are all operating in different states, and there are different things that people need, and so the value of local support is obviously really important. And I guess the other thing that I noticed about what you did was that you're thinking longer term and broader, so you're thinking about even things like Maslow's hierarchy of needs. You know, if she needs a place to sleep, she needs safety and so on, before you can address complex mental health issues. And at the same time, the issue
that's definitely my approach,
Yeah, but you're also respectfully addressing the thing that's really bothering her, which is what's going to help her engage.
Yeah, and the reason that I do that is because the cyberbullying is the immediate issue that's presented, but there are also lots of other issues which will compound the stress that Kelly may be feeling at that time about this experience. So with all that going on for her, because it is a complex case, then it can make the cyberbullying perhaps feel worse for her.
Yeah.
Because she has little support.
Thank you, Brooke. So now I'd like to invite Dr. Simon Kinsella to just talk to us about how he would approach this as a psychologist. Thanks, Simon.
Thank you, Mary. And I guess just to pick up from where Brooke left off, and the comment about Maslow's hierarchy of needs, as a psychologist in private practice, I really need to be sure before I get engaged with a young person that those basic needs are being met. I've found that there's very little point in me being involved as a private practitioner if those issues aren't being addressed in some ways. And sometimes they're not, the situation's not clear. But so long as somebody is working with the person to try and identify a suitable accommodation and have those basic needs met, with the psychological work can then begin.
Which is what I do, Yeah,
that's right. That's what I'm picking up on.
And I guess, Simon, can I just say, I guess a lot of the people that get referred to you actually haven't had somebody like Brooke helping them get all in that place. All that in place before they come to you.
No, well, that's right. And so sometimes I am in a position where I need to be saying to them, it's not going to be terribly helpful for me to get too involved at this stage unless we can link you up with the right person to sort out your accommodation needs or make sure that you're in a safe place. Because the psychological work is very, very difficult to do if they don't have a roof over their heads. So where I would always start, and this is perhaps regardless of whether a GP's been involved or a social worker or a psychiatrist for that matter, is just satisfying myself about what's going on from a psychological perspective and looking at the potential diagnoses. So as a CBT practitioner, we use this biopsychosocial model to try and get as complete a picture as we possibly can of what's going on. And I guess in talking about my position relative to other practitioners, my process of going through and making an assessment for myself is not any reflection on what I think of other practitioners, but it's more a ethical responsibility position. And as somebody who sits on panels hearing about unethical practice, we do hear scenarios where practitioners have just taken a diagnosis that's been given them and run with it. So I like to satisfy myself, first of all, that we've covered all those bases. So from that perspective, I'd work through usually starting with biological issues, because they tend to be the things that kids are often more comfortable talking about. Things like sleep hygiene, for instance, and physical fitness are often a really good way of easing your way into an assessment. And as the young person becomes more comfortable with you, then they're perhaps more open to talking about things like perhaps their drug and alcohol status or other physical health issues. I think, you know, in a case like Kelly's, I guess I'd be concerned about what sort of physical risks she might be exposed to if she has been on the street, whether there's, you know, whether she's looking after things like her nutritional needs and so on. And again, for somebody like Kelly, that's actually going to be potentially quite difficult if she hasn't got access to some of the basic needs. Then tend to move on to the psychological more than the social. And even though in this case she's presenting with cyberbullying as an issue, we've already got a lot of information, and usually when I've had a referral from somebody like Brooke, I have been given a lot of very helpful information about things like the history of depression and so on. So I'd be getting into further exploration of what the cognitions are associated with the depression and anxiety, and what the behaviours are that might have come up as a result of those mental illnesses. And again, with a very complex case like Kelly's, I'd be concerned about the possible history of abuse. There's that question mark of sexual abuse, but we often see other issues of perhaps physical abuse or neglect in scenarios where families have broken down. Of course, and I probably should have said this earlier, one of the things I would be very on guard about, I guess, is the risk assessment, making sure that I was satisfied that there were no suicidal tendencies, and satisfying myself that at least she's safe enough to be out in the community. I'd be looking at things like the history of mental illness, and both her history of mental illness and perhaps a family history where that's available. And then, of course, coping mechanisms, her strengths and weaknesses, in spite of the fact that this is a scenario of a person that's had quite a difficult life. She's actually shown quite a lot of strengths as well. She's exploring her sexuality, but she doesn't seem to be doing it in an overly risky way. She's mindful of things like how her sexuality is going to be interpreted by her peers, and she's talked about being a little bit guarded about her sexuality. In this case, she wasn't guarded enough, unfortunately, and that's what's perhaps triggered the cyberbullying. But there's those sort of indications of social awareness, and there are perhaps some strengths that I might look at working with as we move on to treatment. And from a social perspective, obviously looking at things like her peer group, and I differentiate peer group from friendship group. You know, when I'm talking about peer group, I'm talking perhaps about all the students that she might interact with, and friendship group is a much narrower subset of that. I'd be interested to know a bit more about her emerging sexuality and what sort of experiences she might have had, and whether those experiences have created any other trauma for her. And when it comes to the issue of cyberbullying too, I'm particularly alert to what kinds of messages the young person is finding the most distressing, because that those sort of reactions are often an indication of what past experiences what past experiences they've had that have left them most sensitised. Always interested in family of origin issues, and in this case she's moved around to a few different families as well, and I'd like to know more about those sorts of experiences, and going back to where we started, I guess current living arrangements, and making sure that those are secure. So once I'd clarified all of those sort of issues in my mind, I'd then move on to how exactly we might approach treatment in this situation. She's presented with the issue of cyberbullying as being the primary problem, and so I would always engage a young person around the primary issue first. So even if I felt like underlying the scenario. There could be depression, there could be anxiety, there could be problematic maladaptive schemas, cognitive schemas. I'd start with the presenting problem and then start to work my way towards hopefully addressing some of those issues. Usually with issues around cyberbullying, social skills are very high on the agenda of a CBT practitioner's point of entry, and assertiveness skills as well. And I notice I haven't put that in the slide, but assertiveness skills are incredibly helpful for people in these sort of scenarios. I'd be more relaxed perhaps about her use of the internet, knowing that someone like Brooke was involved and someone was helping her to understand what she could do to protect her needs. But in some cases where I don't have somebody like Brooke involved, I might actually also spend a bit of time working on internet safety and strategies that they can use around that. With such a complex case, I would be very concerned about the possible need for longer-term treatment than some brief social skills or assertiveness skills training. I'd be weighing up in my mind whether I felt I was the best person to do that. As a CBT practitioner, I have my approach, and I'm very conscious that often that's not the best approach for certain individuals. With a person who probably has some attachment issues as well with her kind of background, I'd be thinking possibly some psychodynamic psychotherapy might be helpful. And then moving on, getting to the specifics of the cyberbullying, I think Brooke's actually covered a lot of this already in some ways, but generally the advice that I would give and the advice that you see on the internet these days is, first of all, not respond to the message or the image. The same kind of advice that we've been giving people in regards to normal schoolyard bullying for as long as I've been practicing. Saving the evidence is critical. If the issue escalates, the victim really needs to have something that they can go to either the school or the police with. And then there's obviously technological things that can be done to block the sender or delete the sender, to manage security settings. The service provider, the website, also can be contacted, and they, Facebook and other similar platforms will intervene in some cases. And that's good to have that sort of technological backup, but it's also critical to have trusted friends and family and adults involved wherever that's possible, because it's those people that are going to be interacting with the person on a day-to-day basis and can provide support on a more as-needs basis. I would also be perhaps working with the client and with the school, and potentially with a larger, with other people involved in this scenario, on connecting them up to the appropriate resources. So if I became aware that there was some cyberbullying going on in a school where there wasn't a resource like Brooke, I might get in touch with the school with Kelly's permission and talk about what kinds of things the school can do to manage it. Obviously also linking them into other resources. As a private practitioner, I often have a scenario where clients can't afford ongoing therapy, and so I'll help them to identify other resources, whether that's Headspace or school-based resources or other kind of resources in the community. And that's it from me.
Thanks very much, Simon. I particularly valued your comment there about satisfying yourself at the beginning that you've covered all bases before you start doing your more specific therapeutic work with somebody. And I think that's probably an approach that we take from any discipline, to sort of having your own a set of things that you need to know about before you get started.
That's right, and it's something that I see a lot of other practitioners do too, that they won't necessarily just take my diagnosis and run with it, that they'll make their own evaluation, which I think is entirely appropriate.
And I think the other thing that what you said raised for me is the idea that, perhaps someone like this with complex needs might be better off with a longer-term approach to therapy, and maybe a brief intervention is not going to be helpful. And I guess sometimes engaging with someone that you can only see for a short period of time can actually be difficult for some people. But I guess it raises the issue of the ideal versus the possible.
Well, that's right.
And sometimes we live in small rural towns, or people have, as you mentioned, limited resources. And so sometimes I find it's a matter of saying to someone, look, this is what would be the best thing, and this is what we can actually offer. What would you like to do?
Yeah, and that's a problem that even in a resource-rich city, that you still end up running across barriers like that.
Thanks. And there's been a really interesting point raised in the chat room by some of the participants about which we will come to, I think, in our discussion later, but I just wanted to flag it now. So there's actually a lot of overlap already between what Simon would be doing and what Brooke's doing, and then we're going to hear from Liz shortly. So that's one of the interesting things about mental health, is that a number of different practitioners have overlap, and there are indeed people that can probably do most of it in one stop. So, for example, the person in the chat room spoke about being a private practice social worker who looks after all that stuff and provides the mental health support. So I guess it'll be useful for us to have a discussion about how collaboration can help and how we work together in our different disciplines. And I guess that's the point of our doing these webinars, and so it's great that that's already come up, and I just wanted to flag with the audience that we will come back to how we work together, and we'll use Kelly as our basis for that discussion. And so now I'd like to invite our psychiatrist, Liz, to speak about your approach to Kelly.
Thank you very much, and thank you very much for asking me to participate in this as well. It's a great opportunity to, as you say, speak across disciplines, and I would like to have Brooke come and work in our clinic, because I was very impressed by how extensive her assessment was, and similarly by Simon as well. So I'm intending to be brief, and I just wanted to talk, as I am a researcher as well as a clinician at Headspace, I just want to talk a bit about the context, put it in context, and then talk about what in psychiatry I would do that might be different in addition to what other disciplines might do, for instance. So I just wanted to talk about some of the research about cyberbullying, of which there is not a lot, as you're probably aware, but it's an increasingly common problem. So particularly in Headspace, we see a number of young people who've been exposed to or involved in cyberbullying, and that becomes an issue in their presentation or in their history or in their peer group. So it's a really important problem of which we do not know a lot about. There's been some research in Australia which indicates about 20% of young people have been involved in or exposed to cyberbullying in some ways. In the Australian perspective, it's probably more common, it's equally common in boys and girls. In a UK report that was released in 2010, it was found to be more common in girls, and boys probably getting more involved in face-to-face bullying. And obviously it's a risk for the onset of mental illness, or contributing to complexity like drug and alcohol abuse or self-harming behaviour. So it's a really important issue in screening patients and assessing patients with mental illness to identify whether these issues are present or currently or in the past. And cyberbullying is somewhat different to traditional bullying in various ways. So we've all had to upskill and educate ourselves, as we have with technology in general, which young people are using. We need to understand more about what some of the differences are in traditional bullying and cyberbullying. And obviously, in cyberspace, people can be much more removed from their, so they're not necessarily going to have the same effects, and some of the characteristics of people are going to be somewhat different. So in terms of victims, probably the feelings of low self-esteem, anguish, powerlessness and hopelessness are pretty much the same as in traditional settings, except it's probably harder for people to escape. Traditionally this would occur at school, and I apologise for that. Somebody just rung my doorbell.
We can't account for doorbells. Mobile phones we can predict.
Yes, so anyway, hopefully somebody will go and answer it. So cyberbullying can occur at home. So it can occur in spaces where people would otherwise feel safe, or when people are on their mobile phone or elsewhere. Victims are at increased risk of suicide. So there's been several reports that have indicated that there's an increased rates of suicide in cyber bullying victims, and that we don't really understand a lot about the long-term effects of these issues, I think, as Simon has pointed out. Bullies are probably, compared to traditional bullies, cyber bullies are not as depressed. They don't have the same mood problems or self-esteem problems necessarily as traditional bullies, and because they're doing this remotely and sometimes anonymously, they often have less empathy compared to traditional bullies, which is of concern in terms of some of the standard ways that we would be trying to help people understand the impact of their behaviours. And the prognosis is worse if you are both a bully and a victim. I'm just going to go and disconnect.
Yeah, Liz, actually, that's fine, because I know that Brooke's been wanting to say something. Brooke, do you want to just say what you were thinking?
Yeah, I was thinking while I've been listening to Simon and Liz, one thing that I mean, as practitioners, we say, well, we just need to teach young people, and I say it as well, we need to teach young people to manage their account, their online account. But what we also need to be aware of is that young people live their life online. So when we say to young people, you just need to switch your phone off or not check Facebook on your phone or whatever, that is what the problem is for young people. They are finding it so hard to actually be able to switch off. So I think maybe one way around this as practitioners is that we kind of deconstruct or unpack with young people, what does privacy mean to them? Do they have a private life? And so if we can explore privacy with young people and help them create some meaning about what private life means for them, then perhaps that could be a starting place for us.
I think that's a really useful approach, and I guess it then gets them thinking about what's important to them that might be getting lost in their need to stay connected. I will kind of divert off our plan, and I'll just ask Simon if you've got any kind of strategies that work or that might be worth a try to actually help people turn off their technology for some periods of time, because it's a really big issue.
It is a big issue, and I see it not only in younger people, but I'm seeing it more and more in the 20-year-olds and the 30-year-olds. And one of the things that I do, without sounding too much like an old fuddy-duddy, I hope, is talk about the fact that we're not actually used to having this much access to technology or this much access to people all the time. And what I've seen happen more and more is people get almost an anxiety disorder around access to responses to text messages and Facebook messages and those kinds of things. And if I'm working with somebody on an anxiety disorder, what I tend to get them to do is gradually expose themselves to the things that make them anxious. So not being in contact will make them anxious. And they need to be able to do that in a supported way with strategies to manage the anxiety, but gradually increasing the amount of time that they spend away from the technology helps them to manage their relationship with the technology and other people. And I've found in my practice, particularly with the sort of 17 and above age group, that they find it very helpful to be able to say, I can understand how this technology is sucking me in to always being online and involved, and I can understand the kind of damage that it's doing to me to always be that connected.
Thanks, Simon. And I guess, both Brooke and Simon have raised a way there of helping young people to see the value in other things. Mm-hmm. So by connecting with people face-to-face, and this has just come up in the chat room as well, that face-to-face relationships have their own unique value, which sometimes gets forgotten. So helping people to reconnect with that then can make the online stuff less predominant in their social lives, I guess. And then Brooke's point about privacy. So what does privacy mean to them? So focusing on positive things in other areas, which will then hopefully decrease the time that they need to spend.
And also just that.
Yeah, Brooke.
So also just that, just to remind young people. So before Facebook was around, for those who, were born before Facebook came about, but what were they doing before Facebook? What did they enjoy doing back then? Did they play a sport back then, or did they hang out with a particular friend that they have noticed that they've lost contact with? Because sometimes they haven't even stopped to think about these things.
Yeah. And I guess there'll come a point when we are just ancient because we do remember life before Facebook. Liz, I'd like to invite you to continue on with what you were saying if you'd like to do that.
Yeah, sorry, my unexpected guests have now arrived, so move somewhere else. The other point I was going to make was about being constantly connected, so which I think you've just identified. But it does have negative effects. So obviously the net is a fantastic source of social support for young people. It's, in terms of peer relationships, access to education and information, access to skills. But being constantly connected can have a lot of negative effects. It can affect your sleep and circadian rhythm, and that's a major issue for us in the community. Young people are getting less sleep, so their sleep is becoming shortened by technology. And if your sleep is shortened, then you're more likely to develop depression or anxiety symptoms, and your stress response is poorer. So the more tired you are, the more likely it is you will overreact to particular things that you experience on the net. You'll have less capacity to cope with it. You'll have poorer resources. Your judgment will be impaired, and your school performance will also be affected. So there is a danger that being continuously connected is a source of continuous stress and has other negative impacts on your physiological system, your arousal system, stress response systems, and on sleep. And that can have long-term potential effects not only on your psychological health but also on your physical health. So those things are a major issue, and looking at ways of encouraging people to do exactly what you've said, Simon and Brooke, get out, play games, play sport, and interact with people face-to-face, take up art, take up the things that people used to do that are a good source of self-esteem and skill are really important. So increasing activity rather than just interaction over the net is really important, and having a good balance of that.
Liz, you were just saying about sleep with young people. I certainly noticed that in a school environment because young people, they can't get to school on time. And they are coming to school a lot of young people come to school and they are really tired. Mm-hmm. Sometimes it's because, like a case like Kelly's, they might not be living at home, or they're living on, house to house, or they could be living in an overcrowded house where there's lots of family members in the one house and they don't even have their own bed. So I think that issue of young people getting enough sleep, it is an important one.
Yeah, and becoming an increasing issue in the community. So from my perspective, the general things are about, as Simon, as you both identified, establishing the technology guidelines early for both young people and their parents or their carers, making sure we intervene early. So as soon as these issues are identified, particularly by school counsellors, that we have an early response system so that we can start interventions early. And obviously multidisciplinary care is extremely important, and being able to access online support when you don't have access to a Headspace site or some other kind of multidisciplinary kind of platform. And knowing how to use the online systems, the ones that Simon has put up, also Reach Out is extremely good, and there are other cyberbullying information lines. So there's a lot of good information out there on the net.
I agree.
So certainly, and then just finally, and I know you're dying to get on to the rest of it, but just from a psychiatrist's perspective, risk assessment is really important for Kelly. She's a very marginalised young person. I would want to know her level of symptoms and disability. I'd want to know why her previous treatment failed, if she used antidepressants in the past, and if I thought they were relevant now. I'd want to really talk with her about what her understanding was of why she was using medication. Did she take it? Did she have side effects? What does she think were the positive and negative effects were? And if I was going to use an antidepressant, I'd be talking to her about how to choose one, why we were using it, what she's likely to experience, and how we were going to monitor it in the long term. So I'll finish there because I know we're running over time.
I think we've already started to discuss. So I think that we'll just get the support people to put us into the discussion frame so that the audience can see us together. And I think there's been some really interesting things come up about who does what. And so I know that, Brooke, you had a question for Simon, which was regarding about, what it's like for a psychologist to work alongside a social worker. So do you want to just ask that question of Simon, and we'll have a bit of a discussion about the role definition issue?
Okay, so my question's for Simon, yeah?
Yeah.
Okay. I wanted Simon to tell me about the opportunities and the challenges in working alongside social work as a discipline, and what do you think the social work approach to practice needs to consider in order to improve the outcomes for young people who we could both be working with?
Sure. Look, I think the capacity to have somebody who's a bit more on the ground with the young person, as social workers often are, is incredibly helpful. And the communication between the psychologist and the social worker can really bring to life what actually goes on in the therapy room as well. So you can help the young person actually to engage in what you're talking about in the sessions, and they can then work perhaps a bit more with the social worker on fine-tuning perhaps some of the strategies and seeing how they work in their real life and how they can adapt it to their situation. And back in the years when I worked in the public mental health system, it was very, very helpful to have social workers involved at that level, and being part of a hospital team, you have a very close working relationship with them too. I think the challenges, and this doesn't just apply to social workers either, this applies to, I think, health practitioners who maybe don't have the sort of diagnostic background perhaps that some of us have, is understanding what the actual diagnosis is and what it means. And I see it very much as my responsibility to first of all clarify it for myself, to discuss it with the other treating practitioners and compare our opinions, and hopefully we're all on the same page, but then to communicate with the schools, with teachers, with parents, with social workers and so on, about what the diagnosis is, what it means, and how it's going to be most effective to work in this person's case.
Can I just add something in there?
Certainly.
Yeah.
Because I find that with with psychology, that if we're talking about something like depression or anxiety, in social work we actually name it up differently. So we say, we don't say the young person is depressed, we say the young person is experiencing the anxiety or the depression. So we use that externalised approach because our discipline is that, if we say that the depression is out there and not in here, then the young person can manage it a bit better. Does that make sense?
Yeah, I don't disagree with that. And I sort of fluctuate between how I use the language. Sometimes I'll talk about it in either way, perhaps.
So a psychologist okay with us externalising the externalising approach, or is that just a social work thing?
No, and different people. For me, while I understand the rationale, I don't have a problem with the rationale at all, but I won't get as focused on the use of language, perhaps particularly in talking to other professionals. When I'm face-to-face with a client, I'll be very careful about the way that I use language, and I'm also very careful to listen to where they're coming from. So if they start from a position of it being very internalised, I'm a little bit cautious about externalising it too fast, because that can cause some friction in the therapeutic relationship.
So I'm thinking, if I'm practicing social work and you're the psychologist, if I'm referring to the young person's depression as the depression, and you're a psychologist and you're saying, your depression, then to the young person, then we'll confuse them.
Well, I guess I wouldn't be dwelling on that language anyway. I'd be moving more to, well, these are the symptoms, so how are we going to work with them?
Right. Okay.
And I think that's raised another point, which I think is about paradigm. So some of our disciplines come from different sort of operational paradigms, and I know that Simon actually had a question as a psychologist for Liz, who's a psychiatrist, exactly on that issue. So Simon, I wonder if you could raise that question.
Yeah, sure. So Liz, I was just wondering from your point of view, how do you manage the scenario that sometimes occurs when you might be working in one therapeutic paradigm and another mental health professional is working in another paradigm? Particularly through my work at Melbourne University, I'm often working with psychiatrists who are more trained in the psychodynamic model, and I'm there to train them in CBT. So I'm just wondering from your point of view how those sorts of things work or don't work, and what could be done to make them work.
Look, I think those are issues. A lot of it can be resolved by communication. One of the things is to try and identify what your key outcomes are, what your goals are in terms of recovery. So both in terms of symptom reduction, but also in terms of functional recovery. What is it that you're aiming for with a young person? You want them to be in school, you want them to have peer relationships, you want them to be able to, have stable stable mood, you want them to have good self-esteem and good kind of cognition. So one of the things is to actually define what the goals are of the treatment that you're providing, and then try and make sure that everybody is actually working towards those goals. And often it doesn't actually matter if people are working in different theoretical frameworks, as long as they're working towards the same goal. And often the more interventions that people get, often the better. So if they get CBT, if they get some therapy, if they get a peer-based kind of therapy, if they're doing some online work, if they're having physical, if somebody's helping them with some physical exercise and helping them with their sleep, it actually doesn't matter if the theoretical frameworks are different, as long as everybody agrees about what the treatment goals are and we're not working against each other. And my experience of working in multidisciplinary teams is that rarely is the case, that generally people have expertise in different areas, and we try and make sure that we don't overlap, so that we don't confuse the young person and that we're not getting them to do things that are contradictory.
And I think, Liz, your point there about keeping in mind the same goals, and hopefully they're the client's goals. So it's about each person's relationship with that young person, and that we're all working towards, what the client wants, as well as what, we feel as a team is necessary. Simon, you were going to say something there?
Yeah, look, this is sort of similar, slightly different though, and it's a thought that I keep in mind more and more when I'm working with young people. I was at a presentation at my child's school about sex education, and the presenter started with the proposition that parents come to them saying that, my child has told me this about what you tell us in sex education. So she said, here's the deal. If you don't believe everything that your child says about what I say at school, I won't believe everything about what what your child says about what goes on at home. So when I'm working with other therapists, I always listen with the third ear a bit and think, well, what's actually happened here? Has the other therapist actually said what I'm hearing, or is this just the client bringing to me what they think they've heard?
It raises an important issue about communication, that if you're working across disciplines, you actually need to maintain contact with each other so that you know that you're actually all working towards the same end, and that can be very difficult if in busy private practices, or in particular regional areas, it becomes extremely difficult.
Absolutely.
So can I ask, on that note, can I ask my question to Liz? I've got a burning question for Liz.
Yes, I'm aware that there's something that we haven't talked about school at all.
Yeah.
It's been coming up. It's come up in a lot of the questions. So you go ahead, and then I may cut you off so we can talk about school.
That's okay. Yeah. So I just want to, this is for Liz, yeah? So Liz, in the helping professions, and certainly for someone like myself who's working on the ground with young people, and like going into their homes, and I'm in their environment quite a bit, and I might talk to them sometimes every day. So in the helping profession, in the hierarchy, like psychiatry is sort of like you guys are right up there for us. And so, like in terms, like for expert, like, okay, maybe the young people are the expert because they're the ones experiencing it, but psychiatry is up there. So my question is, for us to be able to work together to achieve the better outcomes for a young person, what's the best code of conduct for me to use to approach you? Like, how do I, is it okay for me to just call a psychiatrist and go, hey, I'm working with this young person, you know, how do I go about that?
Look, I would encourage you in as direct a way as possible. I work at Headspace, and we work in a very flat system at Headspace, which is the way that I really like to work, and I think it works much better for young people as well. It provides much more flexibility, and it's much more respectful of other people's areas of skill. And so I rely a lot on the allied health staff who work with me. So I rely a lot on my mental health nurses who have specific skills, on our social workers and our occupational therapists, in addition to psychologists who provide a lot of the much more specialised psychological therapies, and I'm extremely grateful to have them in my team. So if we're working together, and generally, I'm seeing those cases, I don't see people as frequently as they would do. So I would see people much less frequently. I would be doing assessments, I would be monitoring people, I would be checking or reviewing them or seeing them if something has changed or they haven't progressed as we expect them to. So I really rely on my team members to tell me what's happening and for their advice as to how to manage things.
Liz, I know that you had a question for Brooke, which I think is really important, which was about how should schools respond, particularly when students are being bullied out of hours.
Yeah, so we have increasing problems, Brooke, with students who are being bullied at school, and we are, and the schools are saying, well, it's not happening in school, it's happening out of school. So, they're very unsure about their responsibilities. And then
I know your question, and I think that has been a real challenge for schools, and I think that in my experience in a school to this point, that's something that we are talking about, because what we're finding as well is that, okay, it might have started at 6 o'clock after school on an evening, but bullying is intentional and it's repetitive. So if that continues to happen, it does eventually come into the school classroom or the school environment, because the conflict is continuing at school. So I think, schools have got to come up with some kind of approach, whether it's that, and each state is going to be different. So, but these are some ideas, like they could nominate like an e-bullying officer at the school, where a young person could go and see that officer, or it could go before a panel of different people in the school. There are another part of this problem that we're experiencing at schools is that it's not just the young people. We have parents that there are some parents who also join in the bullying online.
Yeah.
So when we're trying to educate the young people, and we don't have positive parents who are helping the school to be able to, promote some good behaviour online, then it makes our job even twice as hard. So, but schools are probably doing more about professional development for teachers, because teachers need to be aware of how to respond to this as well. So I think that this topic is something that is in process at schools, and it'll be different for each state. And also it can be each school, each state has their approach to cyberbullying and a policy, but how each school can add to that and complement that process by how they do it internally. Some schools will use the restorative justice type approach, but I think that cyberbullying is calling for a little bit more than that.
Simon, you had an interesting...
Yeah, there's now technology that schools can buy to put on their intranets. And the way the technology works is it picks up on specific terms that are being used that might indicate that there's bullying or that there's somebody at risk. And then it notifies somebody within the school. So it might be an IT person or a pastoral care worker. And then those people can then approach the young person who's involved and ask if they want help. And that's been proven in a number of schools to be an extremely effective way of getting in touch with the victim, who perhaps might not have known how to handle the situation, and then facilitating some sort of solution.
And the difficult thing for schools as well, Liz, is that if young people come into the school and say, this person's giving me a hard time and, this is it's all hearsay unless we have some evidence. So that's why I say to young people, you've got to print out the transcript and bring it to us.
Yeah. And these technological solutions help with that too, because they feed the information straight to the school too.
Yeah.
And I think, Liz, because you work in that team at Headspace, I imagine that one of the things that you guys can do is provide support to parents as well, and that's been coming up in the chat room. How do we support parents to assist their young person if they're in this situation? I mean, in Kelly's case, she doesn't have that, but some kids do. So what advice or information can we give parents? How can we help them?
Sorry,
Liz
Liz.
first, and then...
Yep.
Yeah.
Look, parents often feel really out of the loop and they feel really excluded. So often young people don't tell their families what are happening because they fear that either they're going to make the situation worse or their technology will be taken away from them. So they often don't report it until late, and then families often feel very helpless as to know what to do. One of the things involving families early on with the young person's permission and explaining why that is helpful to do that, because they're likely to need support. And if you ask young people who they want to support them, it's generally families and friends rather than a counsellor or somebody else. They're the people that they would go to first. And part of that, I think, is providing education up front. So like all early intervention, the more you preempt things by when students enter high school, making sure that students and their families are aware about the risks, aware about what programs are available, aware about what they can do if something happens, who they can talk to, how they can seek help, what's available online. So as much information as possible. And then if something does happen, to make sure that they're really involved in trying to solve the problem and support the young person going forward.
Thanks. And Brooke, you were going to say about parents there?
Well, there's, I know there's probably scope for some schools to do some workshops for parents to teach, because what I tend to find that what happens is that the parents feel like they don't like to put in, they've let the young person have this online life and then all of a sudden want to rein it in because they're seeing that it's causing some problems. So parents need to be educated about what their rights are as parents. Because sometimes they forget that, until the young person turns a certain age, they still have rights with their son or their daughter. So it'd be good to educate parents more and provide workshops, through schools to help educate parents and let them know what kind of support the school can offer. Because some parents don't know that some schools can offer so much support.
Thank you.
If they have the resources.
Yeah. As expected, the time has flown, and what I'd like to do is invite each of the panel members just to have 2 minutes to just sum up, what's been valuable for you from this and what you think the key messages are that you'd like the audience to take home. And I think I'll ask Simon first, if you'd just like to have your 2 minutes.
Sure. Look, I think the discussion tonight sort of reinforced my experience that the more communication there is at all levels, the better. Whether that's communication with the client or between practitioners or between the practitioner and the school. There's if you can facilitate a discussion, and if that can involve the parents as well. That's most likely to lead to the best outcome for everybody. And when I say for everybody, obviously I'm talking about the client, but I'm also talking about assisting the school to develop the kinds of structures that they might need to put in place to minimise the risk to other young people.
Thanks, Simon. Brooke?
One thing that I probably would like to add is that in cases that are as complex as this one, is that the minute that a young person disengages or that a student disengages from school, we can lose contact with them. So if we're like with Liz, like let's say if they're on antidepressants, or if we're trying to follow up something with them and we've got halfway, in doing some good work with them, as soon as they disengage, you might see them 2 months later and they haven't been able to afford their medication and they've gone off their antidepressants, and sometimes we have to go right back to square one and sort of re-engage them with that sort of stuff all over again. So monitoring the young people, monitoring in a good way, but keeping an eye on them and having and sort of following through on that long-term plan with a young person who's experiencing all these issues that someone like Kelly is, can work well as long as Kelly keeps attending.
So I guess a strategy for that is maybe involving an NGO that doesn't necessarily operate through school.
Yeah, that can complement our work as well, yeah.
Yeah, and I know that there's a lot of NGOs that have programs that are specifically around young people that are at risk of disengaging from school, and I think there's been quite a lot of resources go into that area because it's recognised it's a place where people can fall through the cracks. So that would be a strategic thing, is to get a support worker from an NGO not related to school, if Kelly is agreeable to that.
Yep.
I just wanted to raise a really fantastic point that's come up from the audience, that it's a useful thing to remind young people, even though it's obvious, that online life is not real life, and they wouldn't. The example was that they wouldn't stand naked in front of certain people or a class full of people in real life. So they need to remember that that's what they're doing in front of the camera.
A really good strategy that I did hear about was to say, just to a young person, if you could think of three really, role models of who you look up to, and then if you had to show this script to them tomorrow, how do you think that role model might feel toward you? So because they're people, like an idol or someone like that. So if they were aware of this situation that you've got yourself into, and that and they saw what had happened, how do you think your role model might respond? So get them to think it, put a bit of light onto it, or I think there was an author I read, Moira Carmody. She says that it's like the sunlight test. So in the light of day, how would this look in front of the next day?
That's really practical. Fantastic. Liz, would you like to just sum up as well?
Yeah, I think 3 points. One, I think this case is a great example of why multidisciplinary care is really important, and if you're going to achieve good outcomes for young people and reduce their risk over time, then you need to work across all the areas that we've discussed tonight and make sure that we engage people and follow them up in the long term. I think the second one is about early intervention. We should, we teach maths, we teach science, we teach English, we don't teach good cognitive skills, we don't teach good skills in stress management and anxiety management, really in very kind of consistent and structured ways. And we have online resources now to be able to do that, like some of the programs through the Black Dog Institute. And we would hope to see either schools or other organisations providing more of those interventions early on to young people, and including their parents in that, so young people can develop skills to actually manage these technologies at a very early stage. And the third thing is that because young people's brains are still developing, so our frontal lobes, which are the bits of our brain that tell us to stop, think, consider, think about how things will look tomorrow morning in the sunlight, young people's brains don't work so well. They're still developing those frontal lobe systems. So we have to make sure that we really have structures around that impose that. So now, because technology exposes young people to all sorts of things that they wouldn't necessarily be exposed to at this age, which is a blessing, but it also has many negative things, we need to think about, as parents, as schools, as communities, about how we manage that information and about how we protect people and manage the brain development that's associated with exposure to that.
Thanks, Liz. So I think we're approaching the end of our webinar this evening, and I think it's been a really lively and interesting discussion. I think we've covered quite a lot of ground. I guess I need to acknowledge there was other things that have been raised by the audience which we just haven't had time to cover. I guess what I'm struck by is, I think, that, as Liz mentioned, working in an organisation with a fairly flat structure, and I think the communication message is so important. And I guess just as a GP, I sometimes get my psychologist peers kind of seeking my advice. They want to say something to the GP, but they don't know if it's professionally appropriate or how to approach it. But honestly, as a GP, and I guess maybe as a psychiatrist as well, sometimes you can feel quite isolated. And in my experience, if an allied health professional has rung me up and said they wanted to talk about one of my clients, I'm usually really pleased. And I can guarantee that the people that are on your mind and you have enough energy around that you need to make that phone call are also on the mind of the doctor. And so if you ring up and you're also helping to support that same person, I think that in most cases you'll be well received. And the other thing about GPs, since I guess in the Medicare system it's GPs who are referring to all the other professionals or psychiatrists, we often don't, we don't, what we operate best on is relationships. So if we know a person, if we know a social worker, or if we know a psychologist, and we feel confident about sending our patient to that person, it'll be the person that we send to rather than a particularly theoretical model. So by you having the courage to make that phone call, and sometimes it's a bit of a wait for them to call back, but if you do that, it will develop a really useful relationship, and I think in the end, that is what is going to get the best outcomes for young people.
I guess there's just, I guess sometimes there can be this just professional fear. If you ring a psychiatrist just direct, they might think, who the hell is this chick thinking that she can just ring me up about a client, so it's always good to check the process out first about ways to talk about a client,
I think Liz is just saying, just do it. Don't worry about process.
Thanks, Liz.
So I would, just as we finish, I would just like to remind all of our participants to fill out your exit survey as you leave. So it's in the resources tab on the side of your screen. So as you're leaving, if you don't mind going to the resources tab and filling out the exit survey, that will help us to continue to improve the webinar series. And I particularly want to acknowledge that your feedback has resulted in a larger platform tonight, so more people could participate. So thanks again very much, and we look forward to as many of you as possible joining us at the next webinar. Thanks very much, everybody.
Thank you.
Thank you.
Thank you.